we're going to wrap up now after talking about efficiency and opportunity costs, and then extra efficiency or beyond efficiency measures. We're going to talk about future directions. Where do we go from here? We know that some things work and a lot of things don't. Future directions and direct implications for policy. So we're really excited to have this panel here. I'm going to introduce the moderators first. It's Dean Jamison, who we all know is Professor Emeritus of Global Health Sciences. He led the Lancet Commission for Investing in Health, has led to some of this thinking around, particularly around extended cost effectiveness and financial protection. So we're delighted that Dean can join us. Janelle is a partner in crime in organizing this conference, so thank you, Janelle. She's been instrumental in getting the Berkeley cohort to the table. Janelle is a postdoctoral fellow at Berkeley. She in health economics, and she focuses on the economics of care for marginalized populations. Our three speakers today actually need no introduction, but I will do it anyway. Neelam Feacham is Associate Professor in Global Health here at UCSF. It would be fair to say, has spent the bulk of her career thinking about financing health systems and how that affects health system delivery, and is an advisor to the World Health Organization and a bunch of other very influential bodies. And so we're grateful for you that you're here to talk about, in particular, universal health coverage. GHECon, I don't know if you guys know this guy, so I'll spend a little more time introducing him. Professor at the Institute of Health Policy Studies. He is the director of global health economics. He's the force behind this entire program, and has spent a lot of time thinking about some of the nuances and cost effectiveness. Much of his work has been in the past in HIV, and I'm trying to co-opt him into thinking about non-communicable diseases. I think it is working. He has been a fantastic mentor to me since my arrival here at UCSF 4 years ago. So thank you very much, Jim. And he's going to talk about how do we use some of these processes in global priority setting. And Justin, I introduced him earlier. I will do it again. Assistant Professor at the Institute of Health Policy Studies and in the Department of Epidemiology. His area of expertise is in behavioral economics, and he's going to talk about the use of incentives and their impact on tobacco control. So, Neelam, take it away.
Great, thank you. Thank you so much. So I'm going to take a very short period of time to just get even broader than where we have been before, because I think the last panel really talked about value in much broader terms. And I'm now, with universal health coverage, going to talk about values, because that's really the driving force for universal health coverage. So, I think one of the real challenges that we're going to have in economics is how, with this new goal for universal health coverage, we make ourselves relevant and we bring the right disciplines together to really influence policy on universal health coverage. So everybody knows what universal health coverage is, but it's basically a very aspirational goal, as it's stated by the WHO, which is all people can access the health services they need without incurring financial hardship. And, nobody's there. But we're trying to get on a trajectory. And there's two pieces to it, and Stefan mentioned them very well: financial protection and then access to quality services. So it's those two areas that have a lot of trade-offs that determine the path to universal health coverage and what a society values at any given time. So I think I borrowed this from Dean, but it's basically these two dimensions: health status and financial protection. This time I just changed financial protection to the x-axis instead of the y-axis. And if you look at, how to get to universal health coverage, you can really take one path toward financial protection, in which case you'll emphasize hospitalization, catastrophic spending, et cetera, or you can take another path and emphasize primary care, public health, and that will emphasize health status. The truth is that it's a long and winding road. Most countries will do one of a little bit and then one of another, and it's really, for the last century, which is what it's taken Europe to achieve universal health coverage, it has been a long and winding road. This is the traditional dimensions of universal health coverage. This is called the WHO cube, the infamous WHO cube. And on the x-axis, you have the population that's served, so how many people are under any kind of a coverage scheme. On the z-axis, you have the services, so which kind of services are covered. And on the y-axis, you have the costs. So what proportion of the costs of those services are covered? And the idea is that you start to fill up this box. So you will never probably fill it up completely, but you start to add more population coverage, you start to add more coverage, services covered under your benefit package, and you start to cover more of the costs, and you will gradually fill up this box. So that's really where we're trying to go. So, as I mentioned, it took about 100 years for Europe to achieve universal health coverage. And of course, in the United States, we know we haven't achieved it yet. So how realistic is this, that we're going to get this as a sustainable development goal? Well, it's very aspirational, so we're going to be directionally correct, hopefully, in terms of how we move forward. But if I look at what Europe did, it started basically with hospital care, and it started with hospital care not for the wealthy formal sector, but for trades and guilds. And that's because the value that was originally placed on healthcare was for the workers. It came out of occupational medicine and occupational health. And then it grew, and it grew to encompass the rich and the poor, and then later on primary care. And it grew for essentially political reasons and not health reasons. It grew because in the 1880s, Germany wanted to bring together the German states. And so this was, universal health coverage was a way to do that. In the UK, after the World War II, they wanted to unify the country. And so this was a way to do that. So it was really politically motivated decisions. And gradually primary care was added, but for the most part, you can see in terms of coverage, by and large, primary care is not 100% covered, even in most European countries. And then gradually, as other services became available, these were added to the mix. And these are all the services that we've been talking about all day today. New technologies, new drugs, new opportunities for increasing health. So there's really no top to this cube, which is why I didn't draw a top. I mean, this can go on forever in terms of adding new services. The more, in recent discussions, and especially with the Commission on Investing in Health, and Dean Jamison is really the architect of this, he has proposed two very alternative paths to what Europe has taken, which he calls progressive universalism. And these are based on two fundamentally different constructs and values. One is that we should include the poor as well as the rich or the formal sector from the beginning, so that the poor and the health of the poor is of high value. And the second is that we should be looking not first and only at financial protection, which is what was done in Europe, but we should be looking at cost effectiveness, and we should be considering those interventions that are most cost effective and have a maybe disproportionately positive impact on the health of the poor. And one road to that is this particular path, which is recommended in the Commission on Investing in Health, which is that there's an essential package of effective, cost-effective interventions or convergence interventions. It's available to everybody, rich and poor, and it's covered 100%. And then gradually, as the fiscal envelope grows, we add more services. And so we're going from what are really less costly, more cost-effective services to more expensive services. The disadvantage of this approach is that even for the poor, for things like hospitalization or availability of a Hep C drug, it's going to be a long, long time before they get those kinds of services, because we're building the package based on cost effectiveness from the bottom up. So the financial protection piece will suffer, or can potentially suffer, in this kind of an approach. So the Commission and Dean recommend a second approach, which is a model where there's a fuller package of benefits. So maybe they would include some basic hospitalization or hospitalization services that are cost effective, but also not too costly and are affordable within the fiscal envelope. And for the poor, they would be covered 100%. But they would also be available for the non-poor. And for the non-poor, they would be covered at some percentage. Probably not 100%, but there would be some kind of cost sharing. And in this kind of model, the trajectory then would be to start covering more of the services in terms of the costs for everybody and more services in general. So that's kind of the trajectory, the path that a country could take if they were going to take this kind of progressive universalism. And this is actually what France has. This is a path that Rwanda has followed. And so several countries have actually done something similar to this. The problem that this creates is administrative more than anything else. It's how do you identify the poor? How do you make sure that when they're coming in for benefits, how do you prevent corruption, all of those kinds of things. Although it's been interesting because RSBY in India has started to do that and they've done it pretty effectively. So there's some learning in this. The thing about all of this is that countries are going to start where they start now, and nobody has a clean slate. So where the typical starting point for universal health coverage in low-income countries is not too dissimilar to this, which is there is a fuller package of services for a group that is usually the civil servants, and it may include some of the formal sector, but it's definitely the civil servants. Almost every country has some kind of coverage program for their civil servants. And then there is direct provision of basic hospital and basic primary care. And so this is not a coverage package in most cases. It's the public Ministry of Health running hospitals and clinics. And I make this very short because the quality of those hospitals and clinics does not really meet the definitions of what we would consider high quality care and accessibility of services. So where does that leave countries? So a typical low-income country in Africa or India, starting in this particular way, has a lot of options. Dizzying array of options. And it's a challenge. It's a real challenge, not only for policymakers, but for us as advisors to policymakers on which direction should they go. And every agency that goes in to advise a country probably advises a slightly different or maybe radically different approach and direction. All of them can work, or all of them can fail. But what a country does is going to be extremely dependent on the political economy of the country. And it's going to be decided by the politicians of the country as a reflection of what their people want, more than what we would think of as the right ways to go about this. And just to emphasize that point, as I was looking at this, I was looking for this presentation, I saw this, and this is actually from a website called www.healthfinancingafrica.org. And this is exactly the challenge that we are giving low-income countries and policymakers. So there's a big job ahead, and I'll look forward to hearing more in the discussion time about ideas you have about how we might achieve this. Thank you.
Thank you very much, Neelam, for a great introduction to UHC. Is a hugely important topic now is in the Lancet Commission report at the Prince Mahidol PMAC conference in Bangkok that many of us recently attended. It was a big topic. And I want to start by just pointing out that the current world record for solving the Rubik's Cube is 5 seconds. So in the time it took me to say that sentence, we could resolve that problem that was posed there.
I think it was a 14-year-old who did it or something.
Yeah, who's been doing it since age 6 or something like that. Yes, we all started too late. Yeah, toddlers. Yeah, it's all quite simple. No, actually, what I wanted to do in the context of your discussion of UHC, but also in the context of a day that talked about many different specific individual cost-effectiveness analyses, as well as the implications of the cost-effectiveness of specific interventions for opportunity costs, as we heard so well from Mark and others, and also the implications for equity, financial protection, and for budgets, as we heard in the last panel. We've been sort of, in my opinion, sort of skirting the edges of a significant transformation in how we go about doing economic analyses. And I want to propose that it's time to up our modeling game. So when we do cost effectiveness, we're usually doing some sort of modeling, Markov modeling, et cetera. And indeed, the kind of work that Stefan's been doing, bringing in these other considerations, is tremendously important in broadening our perspective. But in the context of the goals that we now have in the world for UHC, for the grand convergence that also anticipated in the Lancet Global Health 2035 report to bring the levels of maternal, child, and infectious diseases down to the current levels in middle-income countries, did I get that right, by 2035, as well as to begin to address NTDs. In the context of the shift from the Millennium Development Goals, which have, where are they? 4 entries: reduce under 5 mortality, reduce maternal mortality, halt and reverse the spread of AIDS, and halt and begin to reverse malaria and other diseases such as TB, to the Sustainable Development Goals, which are giving us guidance for the next 15 years, which has a list of about a dozen. So the process to create the Millennium Development Goals was, I think, sort of private and bureaucratic, not in a bad sense, in the sense that people were able to think carefully about where, this was 15 years ago or so, where to best focus global health efforts in order to make the biggest impact. And the selection of goals was both concrete and focused on the things that where we can make the most difference in the countries that needed the most help, to the Sustainable Development Goals, which had a very, very open process. Many people think open to a fault, in the sense that just the health goals under the SDGs covers pretty much everything you can think of. And I'm not going to read the list. If you want to know the list, I'll give you the website afterwards. But it's very long, and many of the goals are either completely unachievable, as in end AIDS, TB, and malaria, or are simply diverse and extraordinarily complex, or not quantified. So in that context, I think as people who do economic analyses, it behooves us to think about how we can advance our methods to inform a discussion that is no doubt shaped by politics, but I think would benefit from the kinds of tools that would allow those political discussions to be informed by sophisticated, here I've listed integrated, comprehensive programming that looks at trade-offs and allows us to explore the optimization of the design of UHC and other big decisions if we want to optimize efficiency under certain constraints. So we want to get the most health bang for the buck with some limits, or if we want to operationalize some of our other criteria like equity, if we want to quantify how much, going to Elliot's question earlier, if we want to quantify how much are we willing to give up health benefits in order to foster equity in the circumstances when there are trade-offs. Luckily, most circumstances, it turns out that equity and health benefit go in tandem, so we don't face that. As Dean said at the PMAC debate, where I felt you guys were so nice to each other, you ended up mostly agreeing. It was a wonderful debate with Larry Gostin, who was advocating human rights, and Dean efficiency. But I think that there will be times when there are trade-offs and there's just difficulty understanding the choices. And I would like to propose that we as a community of people who do this kind of work should begin to bring together the very, very important messages that we're getting from York and Cambridge, Boston, et cetera, and work on that together.
I was tasked with talking about something I think a little bit different, focusing in particular on tobacco control policy, which, as you all know, tobacco is one of the biggest contributors to non-communicable diseases worldwide. And so in particular, I wanted to talk a little bit about how economists can approach tobacco control policy, what sort of contributions they can make, and then also talking specifically about what the area of biggest emphasis for me, which is behavioral economics. And just to tell you briefly, behavioral economics is essentially trying to incorporate insights from psychology into economic theory. And in particular, there's an emphasis on the ways in which people's behavior diverges from what standard economic theory, rational choice theory would predict. And so I think Stefan's presentation before used the word aspirational, I think, and I think that's actually would be fitting for thinking about where behavioral economics might fit in, but I think it is another dimension that I think belongs within all these discussions, in particular because I think, so in terms of the what behavioral economics is really focusing on is the idea that people not only might impose costs on others in terms of externalities, which is the traditional focus of economics and as it relates to policymaking, but also around internalities, which is the cost that people might impose on themselves by making potentially or not the best decisions. And so I think tobacco use is really a leading example there, one of the canonical examples that people use. And so hopefully I'll be able to talk a little bit more about that as we go along. So I think in terms of where behavioral economics fits in, I think there's a couple ways. So one would be around regulatory science, and that's the part that's really speculative at this point, I think, in terms of making a difference. And so I think overall what economics brings to tobacco control is around tobacco taxation in particular. And so thinking about how should we set these taxes, both in terms of efficiency. So efficiency traditionally thought in terms of maybe balancing out externalities, but also bringing it into it, how to incorporate the costs of internalities that I referred to earlier. And so it's really challenging to actually measure these things. So one of the common stylized facts that people throw around is that 90% of smokers have regret around smoking. And so how do we put a cost on regret, right? That's pretty challenging. And I think that gets back to the discussion we had earlier about cost-benefit analysis versus cost-effectiveness analysis, and cost-benefit analysis, which is basically putting a dollar value on either a person's life or extending a person's life. And this is similarly trying to basically put a dollar value on regret. And so I think that behavioral economics can, in an ideal world where you can measure these things, can really enhance valuations around policies, both in terms of tobacco taxation or any sort of policy when we're thinking about cost-benefit analysis. I think it would be an important dimension. And so I think that's the real challenge, is trying to measure these biases, and I think there's a lot of efforts to try to do that. And nobody's really figured it out, but I think a lot of it, the work that's done right now is around specific models. And so you might have heard the terminology quasi-hyperbolic discounting when you're thinking about how people have this bias for the present, which is very prevalent for basically all addictive substances. And so I think that's the challenge, is to figure out how to identify and monetize these biases. And maybe if there's more time later, I can describe some potential approaches, but it's really a challenge. The other thing I would throw out is in terms of interventions, and specifically around personal incentives. So I think personal incentives you're all familiar with, and it's pretty controversial, I think, within the public health community, probably less so within this room, but there's a lot of challenges that come with that. And so I have a long list of things that you have to sort of overcome when you're thinking about incentives, in terms of, is this just going to really affect short-term behavior? What are the issues around coercion? What are the issues around crowding out intrinsic motivation? And there's a lot of other problems too. And ultimately, I think, incentives work, I think, to some degree, for some behaviors more than others. For smoking, I think that really the evidence remains to be seen, but I think that there is a lot of potential there, so I think that I would push for moving beyond just monetary incentives, and maybe taking a broader viewpoint of how to basically influence people's behavior to promote health, using, for example, social rewards. And you think about adolescents, that's obviously a clear case where moving beyond money can, I think, be really effective. So again, hopefully I'll have a little bit more time to come back to that later and talk about the details.
We'll have some questions. Janelle will begin from within the panel for a little while to carry on the conversation that just began, and then turn to all of you for either reflections or questions on the topics that have come up. So let me turn to you, Janelle.
Great, thank you. So could you talk a little bit more about how we in this room can help support countries in achieving universal health care?
There are other areas of economics that we really need to bring to the table. And I think behavioral economics is very important. I think political economics is very important, the whole political economy, people who understand the political economy. Macroeconomics, we've been talking this morning about who makes these decisions. And these kind of universal health care decisions are really made at the president level, and at least at the Ministry of Finance level, and not at the Ministry of Health level. So I think that's really, really important, to bring in the people who really can talk that language. And I guess the last group of people that we don't hear too much about is actuaries. I mean, if we look at who makes decisions about benefit packages in the rich world, in our universal health care, it's the actuaries. It's insurance actuaries. And they have a very different way of costing a benefit package and determining utilization. And they understand the effects of different co-payments on different utilization of different technologies in a way that we've never had to do in traditional economics, except maybe you, Jim, I don't know. But I think we have to bring them to the table. I think they need to be part of the group that we bring if we're going to go help a policymaker or help a country to decide how they should move forward and how much it's going to cost.
Thank you.
Thanks.
To build on that, Jim, can you talk a little bit more about why is there a focus more on benefit packages instead of individual interventions? And can you talk a little bit about the methods for each? How they differ?
So I'm not an actuary, but I completely agree with what Neelam said, that the actuaries have a really critical role in UHC, because before we were talking about, well, what health benefit would we get for each dollar spent, how many dollars per quality gained, maybe we would look at potential budget implications. But to put this all together and to say, to cover services for hospitalization for a certain class of diseases, how much do you need to charge each person per year as part of their premium in order to cover the very small possibility of a very large expenditure? And that's precisely what actuaries do. And I think the reason that we need to begin to think in those terms is you can't pursue any path on the UHC framework unless you have a way to finance it. And the financing that's most commonly discussed is insurance schemes. It could be public or private, and any of those will need actuaries. If you cover things for which you don't have money, you'll go bankrupt, and that will not put us forward on the UHC path. So I do think that understanding benefit packages and understanding the likelihood of use of those services. And I'm guessing that although actuaries are very sophisticated in established health markets like in Europe and the United States, that they may not know yet very well what the uptake is going to be, particularly for certain kinds of services once people are better covered. So it's going to be a learning curve.
Justin, do you think you could talk a little bit more about how behavioral economics can play a role in cost effectiveness going forward?
So I think, to be honest, it would probably fit, as I was alluding to earlier, I think it really fits a little bit more within cost-benefit analysis than cost-effectiveness analysis. And specifically, I think the work done today is really early on, and I think it might not be sort of ready to take to the policymakers. I think that we're still in the early stages of developing the methodology and standardizing it in a way that I think can be applied more broadly. But I think that the main work to be done is we have already, there are some models around particular behaviors. I mentioned earlier present bias being one of them, which is the one that, to the extent that you're familiar with these various behavioral cognitive biases, as they're sometimes referred to, I think that's sort of the leading example for as it relates to tobacco use. And I think that there's a model that exists. It's just a matter of how do you measure it. So, we have this utility model that builds into it some sort of, it's an extension from the rational choice, utilization maximization model. But there's not really any good way to go about really figuring out what people's preferences are. And I think that's going to be a big challenge moving forward. And so I think that it's something in my own research that I've been grappling with, that we're trying to, there's a lot of work right now on discrete choice experiments. And I think one limitation of that is that especially when you get into something like tobacco use, if you just ask people what they would do, they don't necessarily know sort of how they'd behave because they might not sort of understand what the consequences of their decisions might be. They can't really grapple with what the extent to which they'll be dealing with temptation, for example. And so I think going beyond just stated preferences, I think it can be really important, but that's very expensive, as you probably know, to go out and collect new data as part of a field experiment that's actually going to visit smokers and follow up with them and measure what their smoking status is. So I think that there are really a lot of challenges. And to be honest, I think that it's going to be a little while before it's something that we can really incorporate into our economic analysis.
Can I ask a quick follow-up question? Justin, I'm going to put you right on the spot, and you're going to tell me you're not ready to answer this question.
I'm ready.
In this UHC thing that we're talking about, what % of the UHC money should go toward behavioral economics?
Interesting. So, that's tricky. So I would say, very little, probably. I think that it's sort of here we are at on a medical campus where there's similar discussions around sort of giving it to basic biology versus sort of translational research, and I think that's a similar issue here that I would leave it to probably maybe the World Bank or the social science funding organizations at this stage for the most part. I think they're in terms of actually bettering people's lives, I think that you do a lot better going for service delivery than really devoting it to this sort of, I think there's a lot of value towards, trying to experiment with new approaches, but as somebody who, it's in my best interest to say, give me as much money as possible, but to be honest, I would sort of minimize it and say small pilots at this point would be the best way to do it.
I wanted to follow up also on aspect of finance of UHC. We talked so far, particularly Neelam, about public finance or publicly mandated finance, and that's most of what the discussion of health finance is about. But is constantly in front of us. In most of the low and middle income countries, something between 50 and 80% of finance is private. Most of that private finance is private out-of-pocket finance. And when a policy advocacy, policy analysis effort like the Commission on Investing in Health advocates using the available public resources, which in a low-income country aren't very much, advocates using those on a convergence agenda, that set of interventions for a population to be more or less free at the point of service to ensure uptake. They're arguing for almost no interventions at all to be publicly financed. So it's a strong, strong set of arguments for private finance for everybody, for almost everything. And occasionally people point to that as the kind of conclusion from things like the World Development Report 1993 or the Commission on Investing in Health. We are arguing for public finance, for private finance for almost everything. And that's because we're arguing for very focused use of the limited public funds. It's an inevitable consequence. The two go together like that. And in terms then of thinking about the finance of UHC, in a way it's a question to me of what chunks of private finance should be crowded out by next by the government as it has additional resources. And of course its resources come in different buckets. Its resources can come from payroll taxes. Its resources can come from general revenue taxes, to take the two biggest sources, and for kind of behavioral reasons, the ways those two resources can in fact be used are rather different. But I wonder, Neelam, if you think about it from the point of view of crowding out private finance, and why would the government get into the business of crowding out finance that's obviously already reflecting choices and values that people have? Why get into more private finance at all? Or why in particular get into private finance of health services for upper middle income people, well-off workers?
So I don't know if I set you up for this question or you just came up with it, but what I was doing at WHO for several years was looking at this whole issue of private finance and how it can be used to complement public finance. So if we look at this bucket of private finance in low-income countries particularly, as you said, it's mainly out of pocket. So it's mainly not risk pooled. So the idea was, should we go the path that Europe went early on and the United States is still doing, which is taking private finance and at least risk pooling it into some kind of insurance pool. And in the United States, it's a lot of for-profit insurance pools and some not-for-profit insurance pools, but it's still private finance. And in other countries, it was very interesting. We did an empirical analysis of what private health insurance or this private risk-pooled finance looked like. And it's all over the map, depending on which country you're in terms of whether it's for-profit, not-for-profit, whether it's publicly, whether they're how it's regulated, whether it's regulated like social health insurance or like public finance, or whether it's regulated differently, what it's allowed to do, what benefits it's allowed to provide, et cetera. So what I would say is that one of the first things that we should try to do is go toward more risk pooling. So if I was going to crowd out something, I would crowd out the direct out-of-pocket expenditures.
And risk pool for what?
Risk pool for those things that are now part of the out-of-pocket expenditures. So that is what people are saying. I mean, that's basically the willingness to pay, right? I mean, people are saying, I really want, I'm willing to pay to buy this service. So at least those services should be risk pooled.
But we have private insurance companies. If
But-
people want private insurance, it's all there to buy.
But it's actually not all there to buy.
Well, no, yeah, I mean, obviously, all these markets have to be developed, but the role of the state is a coercive one here. It's to force people to buy. Do we?
Do we want to
when do
have
we want to
mandatory
use-
private
When
health
do we want the
insurance?
state to pay? When do we want the state to force somebody to use their own resources against their will to purchase health insurance? I think they're good answers to both
Yeah,
questions.
I mean-
I'm happy to see the state use its coercive power for these purposes.
Right.
But a lot of people are uncomfortable. Some of the behavioral economists find it a step too far to over.
Well, I mean, you know, and you're talking about mandated private health insurance or you know, and many countries have that. And many countries have incentive structures, like, for example, Australia gives a 30% rebate if you purchase private health insurance. Because it takes the pressure off the public system. So if you can afford it and you purchase private health insurance, you actually
Subsidy
get
for the rich kind
yeah,
of thing.
exactly, a
That's
subsidy
nice.
for the rich.
It's good to
Yeah,
have.
to get, I know you're all for subsidies for the rich. But I mean, you know the answers to this. I mean, just, it's typical, you know, economics answers. There's a lot of externalities to health, so, you know, there's a lot of reason why you should mandate it. I mean, we do it in auto insurance, why shouldn't we do it in health insurance? But, you know, again, this is so much based on the values of the country in terms of what you think of as your individual rights and what the role of the state should be.
Mark somewhere?
I was actually hoping I could ask a question. my name's Mihir. You guys might know me better as guy with microphone. I'm actually an undergraduate student at UC Berkeley right now, and this question kind of came into my mind since the first panel. But I was hoping you guys might be able to provide some insight on it, especially with regards to universal healthcare. I'm actually a hemophiliac, and there's been some stuff published recently, but just in general, it's one of the most costly diseases to try to regularly treat. The bi-daily doses can be anywhere from 50,000 to 100,000. Thank God for insurance. And so what I see, though, is that there's a lot of research that's going on in terms of making that recombinant factor last a lot longer in terms of gene therapy and other things of the sort. And so when we talk about financing healthcare and financing healthcare dispersal in different ways, is there a space to also talk about financing research specifically so that it might provide much more of a long-term solution to a lot of the stuff that we're spending on right now?
That's something I've been interested in for a long time, is financing of health research and new product development, the incentives through the patent system, and where the patent system fails to provide adequate incentives. And I think the arguments that you're suggesting should be made for a large economy like that of UK, United States, France, they can justify in terms of their own population size very substantial investments, much of it public, some of it private, quasi-private. It's private finance, usually financed through a patent system, which is a form of mandatory extraction of high value from the patient for a less costly drug once it's produced. So it's a public form of public finance as well. So it's that there should be a vibrant public finance of one sort or another seems to me essential to the success, enormous success we've seen. It's a harder question for the main diseases of the poor, where there's not the incentive in high-income countries to develop the anti-malarial vaccines, new anti-malarial drugs, even to some lesser extent on AIDS. And the Lancet Commission's taken a very strong position that a much larger fraction of aid for health should go toward financing new product development and research relative to country-specific assistance with immunization programs, for example. And to say that that has been a message that has not resonated would be an understatement.
Clint Pachenko Path. So I have a two-stage question, and it's first, why haven't we brought in more behavioral economists, more political economy analyses, all this sort of stuff? Why hasn't that happened yet? What can you do about it? And the second stage is, why haven't we included public economics in this? We're all talking about these questions from the perspective of this is the money we have to deal with, but why doesn't this community talk about how do you increase the size of that pie?
I mean, I think there is a big role to be played by both public economists and behavioral economists. And for example, oftentimes you can say earmark tobacco taxation or sin taxes to provide revenues. I know that one of the biggest success stories recently is the Philippines, which increased the tobacco taxes in late 2012, and they allocated 80% of the revenues to universal health reform, universal health coverage, and that was the big reason why it was able to get passed, is because that was on the agenda. That the president didn't really care about the taxes per se, but cared about tax reform more broadly and about universal health coverage. And so I think that there is a lot of opportunities there. And then I think the behavioral economics side is more at this point on the interventions in terms of coming up with more effective interventions. And I think that that's less the emphasis in terms of the discussions here today about valuing health. And so I imagine that's why that hasn't come up more often.
And I think it's changing. I mean, I think as we put universal health care on the agenda, it is changing. I mean, at a recent meeting that was kind of post-commission work on UHC, we had a political economist there. We had people from different disciplines there. And it was very, very useful. So I would say that really needs to continue.
Laura Di Giorgio from Part as well, Seattle. I have two comments. One is for Justin. So what do you think is the role of behavioral economics and our responsibility to work with policymakers? When I'm from Europe and when I moved to the US, I'm really attentive to nutrition and I try to have a healthy lifestyle, and I found it really amazing how I could find sugar in ham, in bread, in every single item, and figuring out a way to avoid and have a healthy nutrition took time, energy, and I believe that a lot of people are not empowered to do that. And at the same time, we suggest breastfeeding for at least 6 months, but then we don't have maternity leave. So how can we achieve these behavioral kind of goals without really talking to policymakers? And this applies to Europe as well, or even in Switzerland, we don't have a long maternity leave either.
Yeah.
And the second comment is about universal health coverage. And I guess my point of view, and there's a personal point of view, is that having access to health is a human right. And to do that, we need to find a way to make it financially sustainable. And we know that from an insurance point of view, we need a large number. And if we segment the population, we're not going to be able to achieve it. And for me, that's the motivation to at least have a compulsory insurance that is at least a basic package. And they found it interesting, also the comment of before, that actually health insurance is not a car insurance that we buy when we need. So there is an element of time, a cross-subsidy between healthy and unhealthy, poor and rich, and young and old people. So buying insurance when I'm 55 is not going to be sustainable, it's not going to work. So there is a lot of just elements from a mathematical point of view for supporting a package that is kind of compulsory from my point of view.
Taking your first question, I think one reason why behavioral economics has sort of caught on is because its philosophy is sometimes called libertarian paternalism. It's the idea that basically you can nudge people towards making the right decision without necessarily totally restricting their choices, depending on what the particular application you're talking about is. And so I think given our individualistic, policy making perspective, that appeals. I mean, in a lot of ways, this is just bastardized psychology that people, psychologists have been doing for a long time. And so I think that's one reason why it is resonating, but I think that more needs to be done to explain to policymakers that, the absence of policies are, you're still basically making a policy by not having a policy, and that, setting defaults, for example, can make a big difference. And you mentioned, eating habits and so diet and exercise and that sort of thing. I mean, I think there are things on the margin that, to the extent that, because government in a lot of places, it's hard to push through meaningful, large-scale policies, and so oftentimes I think you have to look towards other stakeholders who, might be able to, align your incentives with them. So, for example, workplaces can oftentimes be experimental sites or for trying to implement policies, and so trying to sort of expand beyond government might be another potential approach, even in low and middle-income countries where there's lots of resource constraints. I think there is still a lot of interest in economic growth and other things that, even if they don't care about health per se, that you still might be able to sort of convince them to work with you. And I think there are tons of small interventions that, can be, like you're saying, so putting fruits and vegetables at the front of the line, that sort of thing that could be done very easily and very cheaply, for that matter.
I just want to make a comment about the mandatory private health insurance, because I think Switzerland has an excellent system of mandatory private health insurance. So they've actually done it. And there's certainly something that we can learn from it as we're going toward mandatory private health insurance. The problem is, in the US, and I think Justin alluded to this, that this basic premise that you have, which I agree with, which is that health is a human right, is not a value of the United States universally. And that really gets down to the crux of the matter. I mean, why it's taken this long to get there and why we still have so many issues moving forward.
I'm Jiyuan Chi from UC Berkeley Demography Department, and my two questions. The first one is there any very important ethical concern about measurements in cost-effectiveness analysis, because we measure many things that cannot be quantified in a traditional sense. And the second question is, what are big challenges immigration will bring to the universal healthcare program in both developing and developed countries?
Well, I think there are a number of ethical issues, of course, and you heard about some of them. One has to do with what's our desire to help the people who are currently most in need of help, as compared with a pure efficiency approach. Another big ethical issue that comes up often is, are we egregiously putting a value on human life? If we do cost per quality gain, and then we even talk about potential threshold and talk about things not being cost effective, are we denying people the right to care? I mean, there's an answer to that, but it isn't, there are various formal ethical systems to address that issue, and so there are certainly the area of cost effectiveness is rife with ethical issues, and on occasion, my good colleague Elliot and I have been attacked vociferously for bringing up cost effectiveness considerations in a situation that others felt was inappropriate. The debate, Dean, that you had with Larry Gostin, where you took the position that cost effectiveness is an important consideration, and I don't want to put words in your mouth, so I turn it over to you. But and that's opposed to a human rights perspective. What was the ethical dilemma there? How would you summarize that?
Well, I think the ethical point was that if you're going to use resources in a way that does not maximize the number of deaths averted from the resources you have, then you are paying for whatever you're paying for your human rights objectives with dead people who don't need to be dead.
I just wanted to comment that the new book on guidelines for cost effectiveness is going to have an entire chapter on ethical questions and cost effectiveness analysis, which is a new addition since the original.
My first question would go to Justin, if you would choose to answer it, and it's that there are times where we have policies in developed countries, and because they have the capacity or the machinery to actually implement them efficiently, they can protect themselves. But this would then deflect the burden or the impact to developing countries which don't have such machinery. A typical example is with the industries, tobacco industry and the sugar industry. When we implement policies in developed countries that say, well, we're not going to take this product, what happens is that these industries would not stop making this product, and then they choose a different market, which is the developing world, which is less well regulated and has a lower capacity. So I'd like to know your thoughts about this and how you propose that we should approach this. That's my first question.
That's your question.
Okay, that's fine.
Yeah, so it's a huge issue. So obviously, many of the tobacco companies are U.S.-based, and so we've exported our habit. So I think in terms of dealing with the industry, I think ultimately it's not really about behavioral economics per se. I mean, I think there are certain things you can do to try to educate consumers, but I think a lot of it is, I would sort of come back to what I guess Joseph was saying, I think, in the first panel about the idea that we need better capacity building. And so I would, better advocacy apparatus, better research capacity building to really sort of have country-specific evidence that you can sort of fight the industry with. And so I think that would be the sort of best thing that I think you could do, probably. It's not sexy, it might not get, for us as researchers, but I think that's probably one of the most important things that we could do to make a difference.
So can we have a round of applause for the panel, and then we'll continue the conversations. I want to take 2 minutes of your time to wrap up. I took extensive notes throughout the day, and I was going to summarize the day's events. It turns out I can't actually read my handwriting, and so this is going to be shorter than I'd initially planned. We've had a lot of fun, engaging conversations today, and a quote comes to mind, and it's the English statistician George Box when he said, "All models are wrong, some are useful." We've gone back and forth on the limitations of this process of addressing efficiency versus equity. Are they truly dichotomous goals? Are they synergistic goals? But there are a few things that jump out. Kirsten reminded us that if we truly care about reducing disparities, then moving the mean health of the population is not enough, and we'll have to invest in that. I loved Elliot's comment that maybe just thinking about thresholds all the time has set us back because they're such a blunt instrument without much of an empirical basis for how we use them. I loved Mark's talk. He did say that, actually reducing heart attacks may increase costs to society, and I was afraid for my job briefly, but the fact that thinking about this in terms of opportunity costs, and the words he used is bringing alive the hidden patient, that when we're making these investment decisions, we're taking these dollars away from someone else's health, whether it is to address equity-related issues or just a sexy new technology. It is, someone else is paying for it. I would, I could go on and on, but there was Neelam's comment saying we focus too much on value in health, and maybe thinking about values in health is another way of tying together this contrast between equity and efficiency. As a recent immigrant to, I should say that we've talked a lot about it as if we're talking about other countries, but many of these challenges apply to us in the United States as well. As a recent immigrant, it baffles me how we talk about healthcare. It's, the red states and blue states pretty much talking past each other. And a comment that Mark made that stuck with me is that so much is lost in the terminology, and maybe we need to bring people together in platforms such as this, where we can have a more nuanced discussion about how we can improve healthcare without trading the size of government off against, healthcare equity and reduction in disparities. We should get other experts here, political economists, actuaries, cardiologists, whatever it takes. But I realize that there are a lot of unanswered questions here, but I come away from this day of conversations feeling like there are a few windows in my brain that have opened up that I didn't know existed, and I would hope that at least some of you had a similar experience. So thank you very much. A big round of applause for GHECon and Devin, who made this possible. And it is time for drinks.
Hey, and a huge round of applause for Kazi.